Understanding Suicide Prevention for First Responders and Healthcare Workers. Thank you for your service as a first responder or healthcare worker. This presentation is for you. If you're in a suicidal crisis, call the toll-free National Suicide Prevention Lifeline at 1-800-273-8255. It's available 24 hours a day, 7 days a week, and is available to everyone. All calls are completely confidential. If you're a veteran, press 1 after you're connected. And if you need to reach the Suicide Prevention Lifeline online, contact them at suicidepreventionlifeline.org. Here's what we'll cover in the next hour. I'll define suicide, suicidal ideation, as well as suicidal plans, intentions, preparations, and attempts. I'll mention non-suicidal self-injury, suicide postvention, compassion fatigue, and moral injury. Then I'll present the general trends of suicide globally. In the U.S., for first responders and healthcare workers where data is available. I'll list the risk factors for suicide, and you'll learn some tactics used to prevent suicide. I'll also show what strategies each healthcare worker and first responder can do to prevent suicide for themselves and their colleagues. I'll discuss resilience and what methods increase resilience. I'll cover the public resources that are available to anyone who's dealing with a suicidal crisis. And I'll list the specific resources available to first responders and healthcare workers who need assistance. Let's cover some terminology about suicide so we have some standard language as we go through the course. Suicide is an acute, which in this case means serious or desperate or violent, and deliberate act of self-harm undertaken by an individual with at least some intention to die that results in death. Some new terminology has come into preferred use. This is how we talk about how people die by suicide. They are no longer said to have committed suicide, which avoids blaming the person who died by suicide. Postvention is a term coined by the father of American suicidology, E.F. Schneidman, in 1972, and is used to describe appropriate and helpful acts that come after a dire event. Suicidal ideations, often called suicidal thoughts or ideas, is a broad term used to describe a range of contemplations, wishes, and preoccupations with death and suicide. There is no universally accepted, consistent definition of suicidal ideation, which leads to ongoing challenges for clinicians, researchers, and educators. Suicidal ideation is on a continuum of severity from fleeting, vague thoughts of death to persistent and specific considerations of suicide. Thoughts may occur only periodically, or they may be unrelenting. The term itself does not define the severity of the ideation. Suicidal plans may also exist on a continuum, from vague and unrealistic to highly specific and doable. They may also include rehearsal or preparation. Suicidal intention signals a high acute risk of suicidal behavior. This includes drafting a suicide note or taking precautions against discovery. Suicidal preparation is also in the same category of high risk, which includes writing a note or diary entry, giving away possessions, writing a will, acquiring a method of suicide like hoarding pills or buying a weapon, making a method more available such as moving a gun from the attic to the bedside table, or getting pills nearby. It also includes visiting a site where the suicide may be carried out, like driving to a bridge or investigating a parking garage that has enough height to be lethal. Preparations also include rehearsing a suicide, like loading or unloading or test firing a weapon, and saying goodbye to loved ones, either directly or symbolically. Suicide attempt is a deliberate act of self-harm undertaken by an individual who has at least some intent to die that does not result in death. An attempt has two elements. There is a subjective level of an intent to die, meaning how intensely did they want to die, and to what extent did they expect to die, and the objective lethality of the act, meaning from a medical perspective, how likely was that suicidal behavior to have caused death? While any suicide attempt is considered serious, attempts can be evaluated both on subjective and objective levels. Suicidal self-injury, or NSSI, includes self-mutilation or self-injury by cutting for self-soothing, with no wish to die and no expectation of dying. It is distinguished from a suicide attempt or suicide because NSSI does not include a desire to die. Self-destructive behavior such as drug abuse, smoking, anorexia, reckless driving, getting into fights may be repeated and may eventually lead to death, whereas suicide is an acute action intended to cause death in short order. Moral injury is the damage done to one's conscience or moral compass when that person perpetrates, witnesses, or fails to prevent acts that transgress one's own moral beliefs, values, or ethical codes of conduct. Silver in 2011 speaks of a deep soul wound that pierces a person's identity, sense of morality, and relationship to society. Moral injury can lead to severe distress, depression, and suicidality. War, abuse, rape, and violence may cause similar types of damage. Listening and witnessing to a moral injury outside the confines of a clinical setting can be a way to break the silence that so often surrounds moral injury. Also, investigating restorative justice where moral injury has occurred may lead to benefit. As a first responder or healthcare worker, you may have heard of the term compassion fatigue. It has two components, burnout, which you've undoubtedly heard of, and secondary traumatic stress, which is the more severe component of compassion fatigue. With burnout, you feel as if nothing you can do will help, or that you're tired, even exhausted and overwhelmed, or that you're a failure, or that you're not doing your job well. You may be frustrated, cynical, disconnected from others, or depressed. And you may also need to use alcohol or other mind-altering substances to cope. Secondary trauma includes fear of situations that others would not think are frightening. Excessive worry that something terrible will happen to you, your loved ones, or your colleagues. It may make you easily startled, feeling jumpy, or on guard all the time. You may feel wary of every situation, expecting a traumatic outcome. And you may have physical signs like a racing heart, shortness of breath, and increased tension headaches. Secondary traumatic stress also includes a sense of being haunted by the troubles you see and hear from others and not being able to make them go away. And the person with secondary traumatic stress may feel that others' trauma is theirs, also called vicarious trauma. Next, we'll report on current information about the amount of suicide globally, nationally, and at the state level, and then discuss suicides of first responders. In February 2021, the provisional death rate for suicide for the general U.S. population was 3,514, based on CDC data. They found that the U.S. population had suicides decrease by approximately 15% from January to April of 2020 before returning to pre-pandemic levels in August of 2020. 14.8 deaths per 100,000 of the general population in the U.S. were due to intentional self-harm in 2018. Worldwide, 9 people per 100,000 died by suicide in 2019. The World Health Organization said, "Suicide is a serious global public health issue, and globally, 703,000 people die by suicide every year. It's among the leading causes of death worldwide, with more deaths due to suicide than malaria, HIV/AIDS, breast cancer, war, or homicide. More than 1 in every 100 deaths, or 1.3% in 2019, resulted from suicide." In the United States, during 2016 and 2017, suicide was the 10th leading cause of death. Using the National Center of Health Statistics, in the National Vital Statistics System shows suicide is the second leading cause of death between the ages of 10 and 34, the fourth leading cause of death between the ages of 35 to 54, and the eighth leading cause of death between the ages of 55 and 64. It is not in the top 10 for ages 65 and older, nor in the top 10 causes of death for ages 85 and older. Ending with the third quarter of 2020, and for the 12 months preceding, the death rate by suicide in Texas was 13.6 residents per 100,000. In 2019, that rate was 13.3 per 100,000 residents. Now let's look at data about suicide for the EMS professions. 28% of EMTs report that they feel like life isn't worth living at some point in their life. 10.4% report severe suicidal ideations, and 3.1% report a suicide attempt. If you're both a firefighter and an EMT, you have an increased rate of reporting a suicide attempt over 6 times that of an EMT. And 37% of those firefighter EMTs have contemplated suicide, which is 10 times the rate for the civilian population. These data were collected using convenience samples, meaning that the population studied was convenient to study rather than a broad random sampling across all EMTs in the nation. And that means that the data may not be as reliable or valid as if collected with a more random sample. Nevertheless, this gives us guidance to consider the rates of suicide for EMS personnel versus the general population using the best data available. As reported for SAMHSA's Disaster Technical Assistance Center, citing Stanley and others, 2015 data showed firefighters had about a 3.5 time risk for suicidal ideations and suicide attempts versus the general population. Information about suicide in law enforcement officers is not conclusive. Some studies report higher, some the same, and others say lower rates than the general population. However, female officers had a higher risk of death by suicide than females in the general population. And work Bishop and Boots did in 2014 showed a 117% greater risk of suicidal thoughts for all officers who reported burnout at work. Theismann and others, in a blog post titled Suicides Among First Responders, A Call to Action, reported that studies have reported that law enforcement officers and firefighters are more likely to die by suicide than in the line of duty. They were citing work by the Rudderman Family Foundation. Theismann and others also reported that between 17 and 24% of public safety telecommunicators have symptoms of post-traumatic stress disorder, and 24% have symptoms of depression. They say, while telecommunicators are often the very first responders engaged with those on scene, research on their suicide risk and mental health has lagged. In the healthcare professions, according to research done by Duthiel, worldwide, the standardized mortality ratio for suicide in physicians was 1.44. Female physicians were at 1.9 times higher risk, and in the U.S., physicians were at 1.34 times higher risk. The acronym LGBTQ2S refers to lesbian, gay, bisexual, transgender, queer and questioning, and two-spirit individuals. Two-spirit means someone who is a Native American or Alaskan Native and combines activities and traits of both men and women and are sometimes intersex individuals. The LGBTQ2S community is at higher risk for suicide due to harassment, lack of peer support, and an increased incidence of mental health conditions and substance use. For LGBTQ2S people aged 10 to 24 years, suicide is one of the leading causes of death, and those youth are 3 to 4 times more likely to attempt suicide, experience suicidal thoughts, or engage in self-harm than their non-LGBTQ2S peers. Between 38 and 65% of transgender individuals experience suicidal ideations. A report on suicide and suicide prevention in Texas by the State Behavioral Health Coordinating Council identified high-risk individuals, including individuals who identify as LGBTQ2S. Others at high risk, according to this report, are shown here. Rodenstein and others in 2016 reported summary estimates of the prevalence of depression or depressive symptoms among medical students were at 27.2% and suicidal ideations were 11.1%. Let's investigate risk factors that increase the risk for suicide. Risk factors for suicide include social isolation, chronic disability, access to lethal means, prior exposure to trauma, substance use disorder, depression, other mental disorders, and chronic pain. But importantly, it also includes a previous suicide attempt by the person, a family history of mental illness or substance use, a family history of suicide, family violence, including physical or sexual abuse, being released from jail, being exposed to suicidal behavior by family members, colleagues, peers, or celebrities, being male, and not having access to mental health care. Events in the recent past may be the push for a suicidal act. This push might include things you might already think about as causal, such as breakups and relationship problems, financial hardships, and legal difficulties. But it also includes public humiliation or shame, a worsening medical prognosis, or other stressful events. One theory outlined by Yassine et al. Holds that suicide results from entrapment, a feeling that the person can't escape feelings, ideas, or events that are no longer endurable. In a 2016 paper, Stanley and others enumerated some reasons first responders, as opposed to the general public, might be at an increased risk for suicide. Acute and chronic dangers to a first responder's health and safety, like the health dangers EMTs experience while dealing with patients with known or suspected COVID-19 infections, or physical risk for firefighters and law enforcement officers, even access to firearms and other lethal methods. For example, a service revolver or access to the drug box by paramedics. The capability for suicide, for instance, because of elevated physical pain tolerance by people accustomed to working through pain, or a lowered fear of death because they're surrounded by death all the time. Erratic shift schedules that cause sleep disturbances and disrupted family life. Stigma preventing utilization of mental health services. And a focus on helping others at the expense of focusing on personal needs. And being involved in multiple high-risk roles such as firefighters who are also EMTs. Role transitions, for example, particularly for those first responders who are younger with fewer years of service, and smaller departments where fewer mental health resources are available. Concurrent or past military experience with combat exposure also contributes to the risk. Clement and others found that stigma towards mental health problems, including suicide, has a small to moderate negative effect on help seeking. Ethnic minorities, youth, men, and those in the military and health professions were disproportionately deterred by stigma. The LGBTQ2S community also experiences stigma, which prevents help seeking. Post-traumatic stress disorder, PTSD, may result after personally experiencing a traumatic event or enduring repeated impactful events over time. In contrast, vicarious trauma may occur when somebody reads, hears, or sees something about an event that causes a post-traumatic stress response, even though they did not witness it. First responders tend to be at increased risk because of their empathetic nature. Vicarious trauma causes the person in a helping role to feel victimized and relive the events alongside their patients or coworkers. It's wise for first responders to be aware that vicarious trauma can significantly affect their psychological well-being, or the level of danger they perceive for those who are important to them. Now we'll discuss some causes of suicide. First responders' health and mental health hazards include exposure to death, either directly or indirectly, exposure to grief, injury, pain, particularly chronic pain. It also includes loss and various types of direct exposure to threats to personal safety, such as being threatened with gunfire, entering a burning structure, or exposure to a variety of health issues as an EMT or a firefighter. Long hours of work, frequent shifts, and longer shift hours and rotating shift hours contributing to poor sleep hygiene. Physical hardships and other negative experiences, including a lack of team cohesiveness, leadership issues, and other issues that affect the ability of an individual to work and survive in these hazardous environments. Some signs of increased risk for suicide include talking about wanting to die or about killing oneself, feelings of hopelessness or having no reason to live, or feeling trapped or feeling in unbearable pain or being a burden to others. Increased risk also includes self-harm like non-suicidal self-injury, and extreme mood swings, an increasing use of alcohol or drugs, and acting anxious or agitated. Other warning signs include behaving recklessly, sleeping too little or too much, withdrawing or expressing feelings of isolation, showing rage, or talking about seeking revenge. And finally, putting affairs in order and giving away possessions are warning signs of impending suicidal behavior. Suicide prevention. As the Suicide Prevention Resource Center states, no single risk or protective factor can fully predict or explain suicide risk. Suicides are complex, with many sources and contributions. Here are some protective factors that help prevent suicide. Having social support or a feeling of connectedness with a person's community. Cultural, familial, or religious beliefs that support a person in times of hardship. A sense of meaning along with goals, hopes, and plans for the future. Survival and coping beliefs. And a feeling of responsibility to family, children, or pets. Other protective factors include fear of suicide or a fear of social disapproval if suicide is attempted, or personally held moral objections. Support from mental health and medical health care providers is also protective. Here are some immediate strategies to take if you believe somebody may be thinking about suicide. If the danger of suicide seems imminent, call 911. Ask the person needing help if they are thinking about killing themselves. This will not put the idea into their head or make it more likely that they will attempt suicide. Listen without judging and show you care. Stay with the person or make sure the person is in a private, secure place with another caring person until you can get additional help on the scene. Remove any objects or situations that could be used in a suicide attempt, including but not limited to firearms, sharp objects, devices used for hanging or strangulation, and medications that could be used. Call SAMHSA's National Suicide Prevention Lifeline at 1-800-273-8255 and follow their guidance. Now let's talk about some self-care strategies that are protective against mental illness and suicide. Mindfulness and meditation classes, use of Tai Chi, massages, exercise classes, group walks, a healthy dietary regimen, and improving your sleep hygiene, which means establishing a routine time to go to sleep, sleeping for the correct number of hours, avoiding things that contribute to sleep disruption like caffeine, and avoiding the use of electronic screens an hour before sleep. Maintaining a quiet, dark, and cool bedroom also contributes to good sleep. Not getting enough sleep is a constant with many first responders and healthcare workers' job responsibilities, but the goal should be to maximize your sleep hygiene, as this is protective of good mental health. Here's some long-term strategies to manage your self-care and to show leadership by modeling these behaviors for others on your team. Seek counseling from either mental health professionals or peer-facilitated counseling where necessary. Practice mindfulness, including breathing exercises and healthy thinking, including meditation. And practice gratitude, in other words, accounting for the good things that are happening in your life. Also maintaining healthy sleep, which we just covered, healthy nutrition, and healthy physical habits, including exercise and taking appropriate rest breaks. Another excellent long-term strategy is to make a safety plan for times of mental distress. Creating a plan is like buying batteries before a hurricane so you can find your way in the dark. It's an inventory of resources customized for you, such as ways to distract yourself when you're upset, people to call with who you can share your crisis, and contact information for your employee assistance plan and other resources like the 800-273-8255 number for the suicide helpline. Here's a link for one created for physicians, which would work well for any healthcare worker or first responder. The Trevor Project, created to support youth, including folks under 25 years of age, who are lesbian, gay, bisexual, transgender, queer questioning, or two-spirit, suggests providing culturally competent care and access to medical and mental health care from providers well-versed in LGBTQ2S issues. They also suggest teaching and supporting the use of conflict resolution skills as needed, restricting access to firearms, developing strong connections with schools through gay-straight alliances, and by supporting family acceptance for sexual orientation or gender identity. Also by providing positive relationships with friends who share similar interests, by the expression of cultural and religious belief that discourages suicide, and by providing positive role models to support self-esteem and good mental health, and thereby reduce suicides in this vulnerable population. Hofstra suggests multi-level interventions provide a synergistic protective effect against suicide attempts and suicide deaths. He suggests this can be accomplished by developing gatekeepers such as teachers and clergy with training to recognize persons potentially at risk. Combining this with a publicity campaign and instructions to the press on how to publish information on suicides. In addition, Hofstra recommends general practitioners could be trained to address suicidal thoughts and behavior in patients. Strategies for healthcare workers and first responders to prevent suicide for themselves and their colleagues. First responders and healthcare workers are often reluctant to seek help. Specifically, healthcare workers fear discrimination in credentialing or licensure if they publicly deal with mental health issues. They also fear adverse effects on their career advancement and consequences from maintaining liability insurance, which is required for their jobs. They are also dealing with a culture that can view help-seeking as a sign of weakness. In the case of first responders, stigma exists around mental health problems, and concerns over the impact of employment, for example, being labeled unfit for duty. There is a culture of acceptance that stress is just a part of the job and should be ignored. This may be coupled with the idea that you should not talk about traumatic events and other occupational stressors. Warning signs of suicidality for first responders reported by Kevis in 2020 include threatening suicide or threatening to harm others, displaying out-of-control or reckless behaviors, feelings of anxiety or excessive worry, insubordination towards others and supervisors. And other signs include an unusual fascination with suicide or homicide, withdrawing or isolating behavior, changes in sleeping patterns, and increased use or beginning use of drugs or alcohol to cope with stress. Methods to reduce the risk of mental illness for healthcare workers include providing mental health via digital modalities and giving frontline staff frequent breaks and providing adequate personal protective equipment, and providing additional support as needed to prevent mental illness. To prevent suicide, Gunnell suggests implementing clear treatment pathways for healthcare workers who are suicidal. the use of remote digital assessment to get mental health care teams in front of the healthcare worker, increased training for the workforce to provide online intervention, and the expanded use of crisis helplines, along with the use of digital resources to train an expanded workforce. Benedek and his team developed 4 pillars of psychological first aid in response to the needs of first responders after 9/11 for folks dealing with psychological trauma during a crisis. Number 1, develop a safe environment for first responders or healthcare workers. 2, enhance efficacy by maximizing the team's ability to care for themselves and for their families by providing proper PPE, by providing clear policies and guidance about what the rules are and how to get things accomplished that they must do. This includes rules for eating, sleeping, where they shelter, how they get vaccinations, and where they get medical care. Number 3, providing the ability to achieve calm by teaching and encouraging and demonstrating relaxation and the use of calming skills. Adhering to natural body rhythms so that nutrition, sleep, rest, and exercise can all be accomplished. Number 4, understand, utilize, and promote connectedness. Maximize and facilitate connectedness to the team members as well as to family members and other social supports. This can foster hope and optimism while dealing with a crisis. Resilience. The Substance Abuse and Mental Health Services Administration, or SAMHSA, said the following issues increase stress and mental health issues in first responders in a report completed in 2018. Unknown outcomes for those the first responder helped. Reoccurring calls, overuse of 911, sleep disturbances, exposure to death and grief. Frequent job changes, no breaks or time off when needed, injury, pain, loss, direct exposure to threats to personal safety, frequent shifts and longer shift hours, and physical hardships. Healthcare worker stress may cause severe distress, burnout, or physical illness, even the provision of lesser quality care for patients. Resilience can be defined as the ability to bounce back from a traumatic event or experience. It's a trait we all possess and something inherently present in all of us. Amy Kevis said this, talking about resiliency among first responders. Another definition is a self-righting force within everyone that drives the person to pursue self-actualization, altruism, wisdom, and harmony within a spiritual source of strength as cited by Richardson and Waite in a 2002 article on mental health promotion in the International Journal of Emergency Mental Health. A third definition is the ability to successfully adapt to stressors while maintaining psychological well-being in the face of adversity. And it acts as a protective factor against many mental health and behavioral health issues, as was written about by Haglund and others in 2007. Some signs of first responder distress and losses of resiliency include the inability to stop thoughts and memories of events that happened hours or days before, difficulty in getting sleep, difficulty in communicating with their partner, not feeling like talking about work, and being troubled by events replaying over and over in their heads, the use of drugs or alcohol to feel better, and not communicating well with others, which Haglund suggests contributes to an increase in risky behavior. 4 components of resilience include adequate sleep, good nutrition, regular physical activity, and active relaxation, including yoga or meditation. Meditation can be as simple and effective as practicing breathing exercises. Additional beneficial strategies are learning about the people you work with, which fosters the team's camaraderie, celebrating successes and mourning sorrows as a group, but also taking time to be alone so you can think, meditate, and rest, and communicating with friends and family as best you can despite the stress of the job. Creating individualized ceremonies or rituals focused on letting go of stress or anger, or honoring the memory of someone depending on the given situation. Protective factors during a disaster to prevent mental health and suicide include social support, especially in terms of good relationships with leaders and coworkers. In 2016 and 2015, Brooks and others found that supportive, approachable leaders and camaraderie among responders helped improve first responders' mental health, while noting that data on the effectiveness of these approaches with first responders groups is limited. One successful approach has been the use of peer-to-peer counseling and peer teams. Sometimes having peers who model healthy behaviors can assist in linking first responders in need of support to additional resources. First responders' psychological well-being was associated with a reduced risk of behavioral health problems. In contrast, poor relationships with coworkers and dissatisfaction with supervisors predicted post-traumatic stress disorder. Use of either formal or informal post-event hot wash, debrief, or lessons learned sessions can build a tradition of discussing what went well and how the team's response could have been improved. After each eventful call or scene, a discussion of issues can also set the stage for these sessions to become routine, provide opportunities for responder decompression, and allow discussions of mental health and suicide amongst first responders to become more normal. Here are some ways the CDC suggests to increase your resilience in yourself and your team. It includes talking with your coworkers, supervisor, and employees about job stress, keeping a consistent daily routine if possible. Get enough sleep, eat healthy food, and exercise. Recognize that you're performing a crucial role. Take breaks with your colleagues, friends, or family to rest, stretch, or just check in. Get help if you're misusing alcohol or drugs. If you're being treated for mental health conditions, stay in treatment and ask for help if new or worsening symptoms develop. Take a break from reading, watching, or listening to news about the pandemic, and get outdoors. Some factors which are predictive of post-traumatic stress syndrome, which contributes to an increased risk of suicide, are young age, low work experience, female gender, a heavy workload, working in unsafe settings, a lack of training, and a lack of social support. This contributes to a 2 to 5 time increase in suicidal ideations, attempts, and death by suicide for healthcare workers, according to an International Journal of Environmental Research and Public Health article published in 2021. Let's look at some symptoms of COVID-19 related stress because of the increased risk for suicide that's being expressed during the pandemic. Feeling irritation or anger or denial, feeling uncertain, nervous or anxious, feeling helpless or powerless, lacking motivation, feeling tired, overwhelmed, or burned out, feeling sad or depressed, having trouble sleeping or concentrating. These could be symptoms of stress related to the pandemic. Here are 10 tips to combat COVID-19 stress from the CDC. For both first responders and healthcare workers, communicate with your coworkers. Remind yourself that everyone is in an unusual situation. Identify and accept those things which you cannot have control over. Recognize that you're performing a crucial role in this pandemic and you're doing the best you can. Increase your sense of control by keeping a consistent daily routine. When you get away from work, exercise to spend some time outdoors, being physically active or actively relaxing. Do things you enjoy during non-work hours. Take breaks from watching, reading, or listening to news stories, including social media, about the pandemic. This can be mentally exhausting, especially since you're already working with people affected by the virus. If you feel you're misusing alcohol or drugs, ask for help. Engage in mindfulness such as breathing exercises and meditation. There are videos about mindfulness exercises on this website. If you are being treated for a mental health condition, Continue your treatment and talk to your provider if you experience new or worsening symptoms. Here are some reminders on when to get professional help related compassion fatigue during COVID-19. Get help if you're not sleeping, eating, or not functioning well. This means you are having trouble doing your job regularly and people notice that things aren't quite right. If compassion fatigue is interrupting your relationships or affecting your day-to-day life, and if you don't feel like you're the person you were before, your mood may be off, and you're not interested in the things that usually interest you. You're worried about things that you can't do and worried about things that you used to like. Or you're avoiding things every time you think about going to work. Get help, protect yourself, and protect those people you serve. Our final topic before we share some resources is about postvention. Postvention is two words jammed together, post and intervention. But Schneiderman created this term in '72, and it is stuck. And he says it's a more significant public health problem than suicide prevention or the management of suicide attempts. It's about the alleviation of stress in the survivors whose lives are forever altered by a suicide. Studies now show that 115 people are exposed on average when a suicide occurs, and 11 of those 115 said that the suicide had a devastating effect or impact. Postvention has 3 goals: preventing further suicides, supporting the bereaved, and counteracting the other adverse effects of exposure. Comprehensive suicide prevention programs and policies encompassing postvention strategies have been developed in the U.S. and in many countries worldwide. Postvention programs are staffed with paraprofessional survivor volunteers. This means they have lived experience with suicide. They provide access to available resources at the scene as close to the time of death as possible. Preferably, they start helping right at the scene. They help with notification of next of kin and dealing with grieving family members. They develop bonds that encourage discussion of grief and hope. They provide choices survivors might not otherwise have, such as cleaning and restoration at the death scene, handling the deceased's personal effects, helping with travel logistics, making funeral arrangements, making decisions about religious observances, settling insurance claims, and taking care of financial costs related to the death. Postvention paraprofessionals can provide support to everyone on the scene of the suicide, including first responders, anyone, including friends, neighbors, co-workers, and distant family members who are often overlooked in that 115 people on average who are affected by each suicide. Dealing with the press. 50 studies found that news coverage can increase the likelihood of suicide in vulnerable populations. So, the press should inform but not sensationalize. Don't put suicide in the headline. Choose words carefully. Don't use the term committed suicide, instead use died by suicide. Report on suicide as a public health issue by including warning signs of suicide and a what to do sidebar if possible. Seek advice from suicide prevention experts rather than quoting or interviewing police or first responders. This is more than being politically correct. It's a matter of saving lives. See the guidelines at this website. Here are some general resources to assist anyone needing assistance with a suicidal crisis and some specific resources for various groups and communities and healthcare workers and first responders. If you or somebody you know, a colleague or someone you love or care about, is in a suicidal crisis, call the toll-free National Suicide Prevention Lifeline at 1-800-273-8255. This line is available 24 hours a day, 7 days a week. The service is open to absolutely anyone, and all calls are confidential. If you need to reach out to someone online, go to suicidepreventionlifeline.org. Here are some guidelines from the McGovern Medical School and the UT Health Office of Employee Assistance and Wellness Programs. that will be useful if you're actively helping someone in a suicidal crisis. First, be yourself. Actively listen. Talk openly and honestly. Ask, have you had thoughts about killing yourself? Don't be afraid to ask questions like, do you have a plan for how you would kill yourself? Be sympathetic and non-judgmental. Don't threaten. Pay attention when somebody's going through a difficult time. Be sure not to shame the person being helped. Try to avoid using stigmatizing language. Try to show compassion. Offer hope, but don't raise your voice. Take the person seriously, but don't act shocked. Accept what's being said and listen. Act to get help as necessary. Remember not to promise that you won't reach out for additional help if the person is trying to hurt themselves or others. And finally, continue to provide support if someone goes through an attempt and survives. Reach out to them and stay in contact. In these situations, it's important to remember not to blame yourself for the situation you've been asked to help with, and there's no need to believe that you must have all the answers. Here's a quick chart to remember some steps to use if you need to help others with a suicidal crisis. First, ask if they're thinking about trying to kill themselves. Next, remove lethal means, including firearms, poisons, drugs, strangulation devices, sharps, and access to elevations that may be injurious. Next, stay present. Stay with the person. Keep with them until other help arrives, and assist the person needing help in connecting to a helpline if they are suicidal or need further assistance. A good starting point is calling 800-273-8255 and follow up, which is good for both the rescuer and the person needing help. If you look at this list, it's modified a little bit so it spells FAST-A backward to make it easy to remember the steps. Here are some suicide resources for everyone. If you're in a situation where somebody is actively hurting themselves or others, call 911. Get help on the way. If they need to talk and need assistance, get them to the Suicide Prevention Lifeline. Their number again is 800-273-8255. Veterans can press 1 and they'll reach a Veterans Crisis Line. If you need to text, you can text HOME to 741-741 to contact a volunteer crisis counselor. And for the LGBTQ2S community, including Two-Spirit people, the National Suicide Prevention Lifeline is the best place to start. There's also a transgender lifeline that supports people who are transgender or non-binary staffed by transgender people. Their phone number is 877-565-8860. For LGBT elders, there is also a unique peer support line. That's 888-234-7243. The Trevor Project for youth and young adults up to 25 is available at 866-488-7386 for LGBT plus youth. They also have an online presence at thetrevorproject.org/get-help-now. In Texas, first responders and healthcare workers have access to a helpline at 833-367-4689. Specifically, law enforcement officers, firefighters, dispatchers, EMTs, paramedics, and public safety dispatchers have services available for you whether you're active or retired, volunteer or career. The Heroes Helpline is also available for healthcare workers, including nurses, physicians, and all other allied health professionals. You must be 18 years or older to use this service. And when you call, someone will speak with you, and if you're experiencing suicidal thoughts, Heroes Helpline will get you to the Suicide Prevention Lifeline. Otherwise, if you need mental health support and a referral to a service without fear of judgment, stigma, or occupational threats, call the Heroes Helpline. Again, that's 833-367-4689.